Good morning, everybody. Thanks for joining in for our Zoom meeting this morning. It's going to be a little different today. I'm trying to change things up for myself, but as well as for you guys so we don't get bored. But what I want to do today is talk about a little bit about why we do some of the things that we're doing. So one of the things that we do a lot of is we talk about competency. And so I want to talk a little bit about competency, why we do this, what does it mean, what's kind of the cool things around that concept. And I'm going to talk a little bit about some of the OBGYN stuff we did ages ago, because I want to bring that back because there's some interesting data there that you guys need to see. And of course, then we'll go into our question and answers and start talking about that other stuff. Now, competency is one of those things that we really focus on a lot here at our shop, right? So we want to make sure that we are well prepared for what we're supposed to do. And a lot of what competency starts out as is initial certification. So here's a bunch of people who are getting ready to do their initial certifications. And so what we look at competency as part of this structure. This is from the EMS scope of practice, where we talk about the different parts of what our system looks like. You get educated, you get certified as competent after you finish your exam, you get your license, and now you get credentialed by your medical director. But the real question is, that's where they say you're competent. The question is, how long does that last? And are we really good enough after we are out for a year, 2, 5, 10 years, right? We really are. Where are we at that point? Now, I may have shown some of you this video, but I kind of want to put it out there again because it really brings to life to me that even in a hospital setting, competency can be a little questionable.
Right there, right. You see it?
It might be that we may just need to because you're
Pull the silent. No.
So for me, and you guys correct me if I'm wrong, what I saw in that video was he was getting right at the lip, ready to get in. He pushed it forward and it dropped down right at the last second. Now we've all been doing a lot more video lately, so we're kind of seeing those behaviors that don't necessarily lead to success. And when you see it pop down like that, I think all of us know that we're probably not going in the right direction. You're probably going exactly where you don't want to go, into the goose. And so the question comes back again. Was this person good enough? Were they well-trained enough? Were they competent in what they were supposed to do? And I got some questions, and there's work we have to do around that space. So for us, it's a work in progress. And this is always the case. So this is why I do so much competency assessment. So we just did core comps, right? And you're probably wondering yourself, so what are we really looking at when we think about core comps? Well, we're looking at the ability to do something successfully and efficiently. Can you safely fulfill the patient's needs in society? Are we doing the things that we need to do? And are we achieving a level that we think that we want our families to have when an EMS professional arrives, excuse me. And a lot of times beginning competency, well, we've defined that minimal competency, but do we really trust it, right? I mean, we could all fill out a sheet. Like, I think we've all remember this sheet from back in the day where you had like a psychomotor sheet that you have to fill out, but do we really think that's enough? And sometimes it's hard to define what this looks like. It's hard to understand, and it depends on the variables and the setting and where you're at. But if we have very clear outcome variables and we predefine these things, we can actually make this valid. And we can actually conduct this in settings that we can control everything. And so this is why we end up in the sim lab, right? Again, these are our beginning kids who are just starting out in the process, who are learning how to do it. We have an instructor on the left here who's showing us how to do it. But in the end, the whole goal here is for us to do competency-based medical education, right? And this is how we define the challenges. The goal is to develop these specific competencies so that we can actually evaluate and get that desired outcome that we want. And sometimes this process is very simple. Sometimes it's much more rigorous. You've probably noticed that we've been moving more towards the rigorous side of things, giving you more challenges, trying to give you more simulations, which are a little bit more realistic. In graduate medical education, we use mastery training as a way to identify a learner, and we want them to achieve a certain amount of entrustable activity. So for instance, if I tell you guys, hey, I want to see your ability to do an intubation, My entrustable activity is that I can leave you on your own to perform this intubation safely without hurting anybody. And those are the entrustable activities we want to get to. So when we think about this concept, mastery learning is an instructional approach that we use to demonstrate that somebody has had enough curricular time to achieve a specific goal. Okay, so our learners are going to hit an educational objective with little or no variation in the outcome in a time period which is undefined. So all of us will reach mastery at different times, but the concept map is that we want you to get there. Okay, and so we want everybody to make that outcome variable of education. That's the whole goal. And so there's a key characteristic of this mastery training, and we call it mastery, but in truth, it's making a specific outcome variable, and you can reach it in lots of different ways. So this is the image I wanted to show you guys. So when we think about where we are initially when we train, you're in this test number 1, where you've learned the skill and now you've achieved a certain competency. So what our goal is when we do any of these core competencies or any of these types of evaluations is we want to shift that distribution. We want to shift it up so that all of us achieve this standardized cut score, which is this higher level of competency, so that everyone is up here, that we brought everyone together at that outcome variable that we need. So that is where we're going for. So I want to bring us back. So now remember I said I want to talk about OB and neonatal resuscitation. And sometimes these things are difficult to achieve in the face that you just don't see these things. And it's hard to achieve competency in something you never see or you very rarely see. So the goal is to leverage this competency-based training through simulation to achieve that endpoint that we want. And so what we did is we got the freaky Noelle simulator. If it was disturbing to you, it was probably very disturbing to me because we had to see it every single day. Her eyes are the ones which bug me out, to be honest. So anyway, with that being said, this simulator actually helped us out a lot. And where it directed to us to was really thinking about what we're doing when we're delivering a baby. And what are those objectives that we need to satisfy? And these objectives are going to revisit you sometime soon. So we're going to be talking again about what do we need to do when we deliver a baby and what are the key aspects. And you guys probably remember Dr. Maxwell, who came over and joined us in a Zoom meeting and gave you guys a number of talks where she talked about, is the baby ready for skin to skin, where we go from the stork delivery to all babies getting dry and stimulate, position that airway, clear secretions, and warm and wrap. And from there, we make a decision if we need to do neonatal resuscitation with the child, which is intervention, versus going to skin to mom and delaying cord clamping so we can have all that good blood flow with all the antibodies, all the protections that the baby needs, and give that baby time to get those treatments. Now, in the process of doing all this, we guys put you in some awkward situations. And if there isn't an awkward situation that you haven't seen, here's a nice awkward situation for you guys. Not the thing that you want to regularly see when you see this group of team. Now, but the key concept was that we had certain competencies that we wanted you guys to satisfy, which you probably didn't even know. We gave you the teaching, but you didn't know what we were assessing, what that outcome variable was. And here they are. So the outcome variables we were assessing was your ability to evaluate the situation, prepare the appropriate equipment, deliver the baby, and then do a neonatal assessment such that you know whether or not this kid needs a resuscitation. So these were the outcome variables we wanted. Now, with that in mind, we also had predetermined cut points and thresholds. So our threshold for competency is we reviewed all the items. So literally we watched every video and scored every video. And we wanted to look at a number of items to be done correctly to be competent. And we had a cut score over 75% to set those things. So again, we went from our test 1, which was maybe possibly a lower level of competency, to a cut score over 75%, so we can be confident that all of you have attained the learning objectives that you needed. So the real question is, did this work? Did we achieve the things that I wanted to get to and get to that competency level so that the work we're doing actually has value? And I have great news. So I'm going to take you through all the data. So here is our evaluation phase. And so you can see that there's some specific things that we evaluated. Checking for crowning, presenting part, vital signs taken on mom, position mom's legs for delivery, recognize need for immediate delivery. So the blue is the yes, the red is the no. I'm feeling pretty good. So from the perspective of evaluation, everyone, after watching the videos, having discussions, having educational outcomes, you guys achieved the outcomes in the midst of all the scenarios that we were doing. When it came to preparing equipment, we also did a really good job. The only place we were falling off was oxygen. And it's probably partly because it's a mannequin situation, right? You're looking at this mannequin, you're like, it's a mannequin. I don't necessarily need to toss oxygen on it. And so that was one of the challenges we had, but the rest of it, you guys did a really good job. Now, when it came to delivery, this was really inspiring. So optimizing position of the mom, you guys did that, correct hand placement, supporting the baby's head, checking for umbilical cord, providing downward traction, and the decision for skin to skin with mom. All of these things were satisfied. And my most exciting is the last one, because that's something that 99% of EMS professionals in the world are not going to think about, right? We have pushed the envelope when it came to that aspect of OB. We've pulled in the new evidence-based concepts of obstetric delivery and applied it to our space to make sure we optimize care. So that's pretty exciting for me. Now, the area that becomes a little more challenging for us is neonatal resuscitation. So this is not something we see very often, ever, right? This is not something we do. And this is where we had a little bit more challenge. We did a great job drying and stimulate. Positioning the airway was definitely a little more challenging for us. Clearing secretions, we did great. Warm and wrap, we did awesome. Assessment for delayed cord clamp was also, again, a little more challenging, but 1 minute APGARs were there and a reassessment of APGARs were there. So we have a couple of points here that we can take away that we need to continue working on, making sure that as a baby comes out, as we're doing the drying to stimulate, make sure we position that airway correctly and move towards the assessment of cord clamping. So when all is said and done, now I've showed you all the 4 key areas. Did we attain the outcome variable that I wanted to attain? And I'm happy to say we did. So competency attainment, looking at our threshold, right? So evaluation, we 100% achieved threshold, preparation 87%, delivery 82%, neonatal resuscitation 74% of our groups attained our threshold. So this is what I want to see. And this is why we do our competency-based assessments. And so in the future, you'll once more revisit probably our OB simulator with Lady Noelle, and you'll have to deliver another baby. But the whole concept here is that we start getting you prepped, start putting these things back in your brain about stuff that you learned ages ago, and maybe even step it up a little bit more so we can have good stories like this. And I love to toss this out there because it's great to see good work celebrated. And it's great to see that we had another baby delivered into our world by a great team of individuals who did an awesome job. So guys, that's what I had for you today. Just hopefully short and sweet, and have a quick discussion about competency, because we just did core comps. Things to expect, things that are coming up right now. So we are going to be having our town hall, and Keating, you're gonna have to remind and maybe say out loud what the dates are, because I've forgotten in the midst of all this. But we'll be having a town hall where we discuss and debrief all of core competencies at all the different stations with the players involved.
Yeah, guys, August 8th, we're doing it at 7 p.m. on Zoom. Probably last about an hour and a half, and yeah, we'll go over core comp stuff.
Thanks, Glenn. I couldn't remember. So that'll be coming up. The other reason I love talking about competency at this time is Cass is going to give us a visit just to say hi, and I'm hoping pat us on the back for all the hard work we're doing. There's been a lot of changes since they were last here, and Eric and I struggled through that first visit, but I think this one will be knocking the ball out of the park. So I'm kind of excited about showing them all the things we've accomplished. So with that, any questions I can answer, guys? More of an update today. So this work that I just showed you is going to be submitted to NAMSP as an abstract. And so hopefully we'll get a couple abstracts out there to show the nation what we're doing. So at that point, I'm going to pass it over to Director Fischel.